Hello, everybody. My name is Leah, and I'm the administrative assistant here at Africa Fire Mission. I just want to welcome everybody to this training today. Thank you so much for coming and participating. And I also just want to shout out our presenter today, Howard. Thank you so much for taking your time out and presenting with us. We're really excited to hear what you have to teach us about first aid. And I just want to remind everybody that this is recorded, and I'll be posting this on YouTube later within the day. So if you want to go back and watch it just to refresh yourselves on the training today, or you can also feel free to share it with your colleagues or anyone else that might be interested in learning about first aid. You're always more than welcome to share anything that we have with your colleagues and the people in your community. And I'd also just want to ask everybody to mute yourself throughout the training. If you have any questions, please feel free to always raise your hand or type it in the chat. I'll be looking at the chat throughout the whole training. So if you ever have any questions or concerns, I'll make sure that I can voice that for you. Or like I said, you can ask it yourself if you just raise your hand. And then I also just want to remind everybody one more thing is that if you stay for 75% of the training, which if it's an hour-long training, that usually looks like 45 minutes, then I will be sending out certificates at the end of the training today. And if your Zoom name is not the name you want on your certificate, please just chat me or you can email me and you can have that name fixed because we want you to have your right names on your certificates. And so I just want to thank everyone once again for coming today. We really appreciate just everyone being so willing to always learn and participate in the trainings. And so now I'm just going to pass it off to Howard and he can get us started on the training today.
Hello, everybody. Let me pull up get my screen ready for you. 2 seconds here. Sometimes it's a little tricky to get this box around it, right? Here we go. Okay. Hi, everybody. Nice to be back here with all of you. So today I'm going to be talking about this. This is going to be an introduction to the principles of emergency first aid. And more specifically, my orientation is when you're a long way from medical care, or it's a really difficult situation for professional medical care to get to you, or you to get your patient to a medical care clinic. My background in this is about 30 years of wilderness experience travel, where we would be anywhere from a day to multiple days away from any kind of other medical assistance. And so we had to be able to provide it in the event of an emergencies. I'm happy to say that I had very few medical emergencies that I had to deal with in over the years, but I was constantly training and retraining on these basics. So this is what I'm going to present to you today. And of course, before I get started, I just want to thank you all for being here, for taking time out of your busy days, especially the end of your day or for the beginning of your shift. Thank Leah and thank Africa Fire Mission. And of course, there's all the many people who I've learned from in the fire service world and in the first responders world in one form or another. I'm grateful to all of them. And I thank you for your service to the people in your community. So with that, this is an introduction to the principles of emergency first aid for first responders. Not all firefighters are emergency medical technicians or paramedics, but often we are the first responders to scenes where it is necessary to provide life-saving first aid. Therefore, it is important for all firefighters to have at least a basic knowledge of first aid. The purpose of today's webinar is to provide foundational principles for responding to trauma in situations where immediate life-saving medical help is required, but not available. In no way should you take today's session to be considered all the first aid training you need. However, with the basic and limited information I will be sharing, and with no other training, you will still have the knowledge to potentially save someone's life. However, or furthermore, I strongly recommend that you follow this up with more formal first aid training. Okay, you're a first responder and you've arrived at the scene of some sort of incident, some sort of accident. It could be a fire, it could be a car accident, it could be somebody has fallen down a cliff, something has fallen on someone, it could be a building collapse. Doesn't matter what it is, you've responded. The number one thing you're going to do in the number one thing you do, which is called the primary survey, is a size up. In the fire service world, we tend to call this doing a 360. In other words, kind of going around the building that's burning, around the incident situation, and getting a 360-degree view of what's happening. As a first responder in a medical situation, regardless of your level of technical first aid training or medical knowledge, when you respond to an incident that involves injuries, your very first task is to gather as much information as you can about the situation. This is done through a careful size up. While you are sizing up the incident, you want to maintain a high level of situational awareness. It is critical that you assess the risks and dangers before rushing in to administer aid. What you want to do is ask yourself this question: what is it at this scene that is trying to kill or harm me? Do not just ask yourself, is the situation safe? That's not detailed enough. You want to ask, what's here that's trying to kill or harm me? Is it traffic? Is it wildlife? Is it a fire? Is it an unstable building? Falling objects? Flooding waters? First and foremost, you do not want to become another casualty or cause further harm to the patient. The last thing you want to do is give your fellow first responders another victim they have to deal with. Number 2 and 3, after you've concluded your scene size up and you know that what's after you and you know it's safe for you to move towards your patient, you want to introduce yourself. Make sure people know who you are. People get scared. They may not recognize your uniform, or you may not have one on for whatever reason. And they're like, well, who are you and what are you trying to do to me? So make sure you know people know who you are. For example, hey, you're a patient. I see you. I come up to you and I say, I'm Howard. I'm a firefighter trained in emergency aid. I'm here to help you. Is that okay with you? You need, if possible, you want to get permission from the patient to be able to work on them. You don't want to put your hands on someone who doesn't want you to put your hands on them. At least here in North America, you can get into a lot of trouble, even if you're trying to do good. I don't know how it would be in your respective countries, but if the patient is able to respond and you're able to ask, is it okay? And you ask them if they're okay with you and they answer, great. Now, you ask, what's wrong? What happened to you? This is really important because if they can answer, then you know, number 1, they're breathing. Number 2, their airway is clear. Number 3, their heart is beating and they are most likely not neurologically impaired. In other words, if I see you, I'm lying there, I've been in a car accident, and someone comes up to me and says, how are you? And I say, I'm okay, but my leg hurts. They know that I'm most likely not about to die, that they've got some time because my airway is open, I'm breathing, my heart is beating. If it wasn't beating, I wouldn't be able to talk. And if I can tell them clearly and respond to their question, then I'm most likely not neurologically impaired. In other words, no brain injury. So first 3 steps of your primary survey: make sure the scene is safe, size it up, identify yourself, and then ask, what's wrong or what happened. Step number 4, make sure you're wearing appropriate PPE. In other words, wear whatever personal protective equipment you're issued or you have available for you. Make sure that you take the little bit of time that it takes to put it on. For example, gloves. If you have rubber gloves or latex gloves, put them on. Possibly a mask or whatever other personal PPE you need in order to keep yourself from becoming another victim. If not in the short term, then you don't want to also have it happen in the long term. And step number 5 in your primary survey. Now notice in these first 5 steps, we have not done any first aid yet. All we are doing is getting as much information as possible before we respond to any one particular patient. Step number 5, determine how many victims or patients you have. Once you've made the scene safe and stable, now is the time to determine how many people are part of the incident. It is easy to get fixated on patients who are calling out in pain or overlook those who are unconscious or miss those who are not visible. Remember, people get thrown from cars. They end up under vehicles or tumble into high grass or undergrowth. You don't know that you won't see them. And if you go right to the person who's screaming the loudest, you might miss someone who's unconscious, not breathing, heart stop, but you could save them. But you went to the person who was making the most noise. If it's night, you might overlook someone. So do your best to find out how many patients you have. That might come by just having people survey around and start counting out the people they're seeing, or maybe asking someone who's conscious and can tell you. It is easy to rush to aid a person whose injuries appear more life-threatening than they are. For example, someone who is bleeding from a superficial head injury might look like they're a bloody mess, but head injuries, scalp injuries bleed a lot. But someone else nearby might have stopped breathing. And because they're not bleeding and they're not screaming, you might overlook the fact that they've stopped breathing. So those are the 5 steps in your primary survey that you need to do before you ever begin doing any actual first aid. Okay, now, the second part of your primary survey is once you've identified your patients, you have to assess them for the 3 main life-supporting functions. And those are respiratory. Are they breathing? Is their airway cleared? Circulatory. Is their heart beating? Is it the blood pouring out of their body? And then the nervous system. Is there a brain injury, head injury, neck injury, spine injury? These are also known as the ABCDs. Now, you're wondering, I said, where do the ABCDs come from out of this respiratory, circulatory, and nervous systems? We'll get to that. So any problem involving one of these systems represents an immediate threat to life of the patient, and it must be addressed immediately. So here's the ABCDs, and I forgot to add in the E's there. There's actually A, B, C, D, E, and E twice. You've made the scene safe. So your size up is completed. The scene is safe, or as safe as you can make it. When I say making the scene safe, there may still be risks to you, but you have to make them limit them as much as possible. And you have a good idea of the number of patients needing aid. And you've initiated a primary survey of the patients by checking the status of the 3 conditions which represent an immediate threat to life. Okay, A and B. I kind of try to do them color coordinated. Airway and breathing. You want to make sure that the mouth and airway are cleared and air is actually going in and out. If a person can talk, they're breathing, and then you know their airway is cleared and their lungs are working so far. So you want to check, first thing you want to check for airway and breathing. How do you check? You look, you listen, and you feel. You look to see if the chest is rising. You listen to hear if you could hear breathing sounds. And you can feel either the breath coming out or you could feel the chest rising. So look, listen, and feel. See, circulation, it's a CB sort of thing. This is not 100% a totally tight system, but circulation and bleeding. You want to make sure that the blood is not pouring out and that it is circulating. And you do that, you make sure it's circulating by taking a pulse. We'll talk a little bit more about that later. Obviously, if a person is pouring blood out of an injured limb, you need to stop the bleeding from pouring out or they will bleed out and die. We'll talk about how you respond to that. And if their circulation, their heart's not beating, then their system is shutting down. And so you have to start the heart, try to get the heart beating. And that's what CPR is. We'll talk a little bit about that. But for the training and that stuff, that's something you need to go and take care of through formal training. D is disability. You want to check to see if the spine is stable and the central nervous system is operating normally. So due to the limited scope of this webinar, I will not be saying much about injuries that involve the head, neck, or spine, except to say that if you suspect a head, neck, or spine injury, at all costs, you do not want to move your patient unless you absolutely have to. And then if you have to, there are techniques for how to do it so that you limit the movement or the head and neck and spine. But it's really, you need to do that with a hands-on practice and would require more time than I can do in this seminar. I also want to say to you that generally in first aid classes, when we say, suspect head, neck, or spine injury, you don't move them and you get them to the hospital. However, in remote situations, there is an accepted method of releasing a person from the immediate concerns of head, neck, or spine injury. And there's a way to check them. But we can't do it in this webinar, but I do want you to know that it is out there. It's a skill worth learning and mastering because many of you will respond to accident situations where you will not have access to more advanced medical care for hours, or you may have to transport a person a long distance. So, but you do want to be aware of that, and to the extent possible, in general, do not move the head, neck, or spine. Finally, E. Now, E comes into, there's two E's here. One is you need to protect your patient from the environment. So where I live, a good part of the year, one of the environmental challenges is cold weather. Now, where a lot of you live, cold weather is not the biggest problem, but heat might be. There might be other concerns that you need to protect them from, maybe rain or rising waters or insects or animals in the environment. So the E is you want to make sure that you're aware of the environment, and that's what exposure and environment are the same things. You don't want your patient exposed to the elements, whatever they may be. And finally, you need to evaluate. Are these potentially life-threatening injuries, or in fact, are they life-threatening injuries? So, which you will have determined that they are if the person can't breathe. But just if you think in terms of A, B, C, D, and E, and it'll remind you of the things, the basic life support systems you need to pay attention to: airway, breathing, circulation, bleeding, disability, and then exposure to the environment. Okay, so let's talk about basic life support. It's known as BLS. Basic life support is the immediate treatment of one of the 3 life-threatening emergencies found during your primary survey, which is what I've just been talking about. The purpose of BLS is to provide temporary support to keep the patient alive while a secondary survey is conducted and/or until advanced treatment is available. This is the tricky part. Sometimes doing BLS is an ongoing process. For example, if you're compressing the chest to help the heartbeat. But if the person stops breathing, then anything you find in the secondary survey is not going to matter because they're gonna die. So, and also, who knows when advanced treatment is going to be available, considering some of the locations you might find yourself in. So keeping the patient alive is your number 1 priority. And I'm going to repeat myself here and say the simplest way to begin a primary survey is to ask the patient, how are you? If the patient answers, then you know that his airway is not obstructed, that his heart is beating, and the brain is functioning. If the patient does not respond or responds in an unusual way, you need to start taking a more close look. All right, so let's talk about airway here. Airway. There are a lot of different ways the airway can get blocked. Airway problems are the result of an obstruction to the pharynx or the larynx. Something in the throat is blocking air from getting in. The obstruction can be complete or partial. A complete obstruction is rapidly fatal, but can be effectively and dramatically treated by clearing the airway. Once I was sitting across the table from a young man who was shoveling food into his mouth. And I was watching him because I was really amazed at how much food he was shoveling in so fast. And then suddenly he stood up and he grabbed his throat like this. And he was just like, his mouth opened, nothing was coming out. And I knew immediately that he had swallowed something and blocked his airway. I jumped up, I leaned him over, and I cleared his airway. It was something, he had something that he wore in his mouth fell into his throat. I cleared his airway, and immediately, he coughed and was fine. But, it could be a complete, and if it's complete obstruction, you don't have much time. You have to clear the airway. There are various ways an airway can become obstructed, such as from vomit, a foreign object, or swelling caused from trauma, or an irritant or allergic reaction. It could also be caused from damage to the airway. It is imperative. You must clear the airway right away. Here's what you do. First, look inside before clearing anything away. It may be that you can see what needs to be cleared out. If there's something there that you could see, use 2 fingers to sweep out the debris. The reason why you want to use 2 fingers is that you want to not, if with 1 finger, you're more likely to accidentally push it in. So with 2 fingers, you want to clear it out. And always, you do whatever you do without causing and trying to cause any additional harm to the patient. Now, sometimes you need to do more than just try and pull out something that's in there. There's 2 techniques that are available. And again, I'm just going to explain them to you, but to really learn how to do them, you need to practice them on either a living person, which can be difficult because our muscles are tense, or a mannequin. But one way is called a jaw thrust. And with the jaw thrust, you're literally pushing the jaw up, opening up, because a lot of times that's all you need to do, because maybe the tongue has slipped back, is blocking. So there's the jaw thrust, you're pulling the jaw forward, and then there's the head tilt chin lift where you tilt the head back and you pull the chin up. The jaw thrust is preferred because with the head tilt chin lift, if you suspect head or neck injury, you don't want to use it. And a lot of times in traumatic injuries, you're just going to suspect a head or neck injury anyway. So the jaw thrust is preferable. Again, because of the time and the difficulty to teach techniques through Zoom, I'm just explaining that this is there. God forbid you should find yourself in a situation where somebody is, you need to do it. At least you have in the back of your head, there are ways to clear out the throat. And if you do it, if you figure out how to do it based on just what we're talking about, that's better than that. That's great. And it's better that you have this as an introduction to the method than nothing at all. So you want to clear it away with whatever's there and open up the airway. So talk a little bit about physiology. Is the patient using extra muscles to breathe? In other words, is there a lot of stress in the breathing? Yeah, you just have to gauge. You have to look, like I said, look, listen, and feel. Normal respiratory rates are between 12 and 15 breaths per minute. So if you're looking and listening and someone is barely doing 5, then they're having problems with breathing, and you may have to assist them by blowing into their lungs for them carefully. You don't want to blow too hard because you'll blow air into their stomach, which can lead to vomiting. If their breaths are much faster, then you need to take that into account and try and figure out what's causing that. And we'll talk more about breath sounds a little bit later. Let's shift now to bleeding and circulation. All right, so uninterrupted circulation of blood is essential to staying alive. No brainer. We all know that. Heart has to be beating to pump the blood throughout the system, to transfer oxygen and bring back the deoxygenated blood. That's what has to happen. If there's a blockage anywhere in the system, any kind of disruption to the circulation, that is dangerous and is life-threatening. The disruption can come from the heart stopping, a vein or artery being severed, and now the patient is bleeding out. So remember, there are basically 2 kinds of disruption. One is when the heart stops, we call that cardiac arrest, and the other is bleeding. So cardiac arrest means the heart has stopped beating. While you're doing your primary survey, if you discover that the patient has no pulse, it means her heart has stopped beating and she is in cardiac arrest. It's important to note that under adverse situations, or if the patient is in shock, it can be hard to find a pulse. We're going to talk a little bit about finding the pulse. The carotid pulse is the strongest to feel and easiest to access. It is found on either side of the larynx. So you can see where my hands are. And if you put your fingers up there, 2 fingers, feel around, you'll find that pulse. If there is no carotid pulse, the heart is not beating, and you must do CPR. Let's be frank here. Even with a lot of hands-on training, CPR has limited potential to restore and sustain life, but it's the only choice you have. These days, here in the United States, what we're being taught is that when you do CPR, don't worry about stopping to breathe, just use the compressions. again, I'm not going to go into the details about how you do the compressions, how far down you press, where exactly you put your hands. You need to take a CPR course to learn how to do that. But if nothing else, and you encounter someone with no pulse and there's no help coming, and you're the one who provides help, then doing whatever you can by compressing the chest is better than doing nothing. Because if you do nothing, the patient will die. If what you do doesn't work, they'll die, but there's a chance it might not, the patient might not. All right, so now let's talk about the second kind of disruption, the circulation, which is bleeding. We will die if we have a major loss of blood. So blood loss must be controlled as part of our basic life saving, our BLS. It's important to remember also that bleeding can be both internal and hard to identify and stop, or external, but not necessarily obvious. We would think that if we have an external bleed, that it would be clear and obvious to us that there'd be all kinds of blood around us, but that's not the case. If we could be bleeding into sand or dirt, even water, or even soaking our clothing and not even being aware how much that there's that much blood happening. And frankly, addressing internal bleeding is just beyond the scope of this presentation and for what most first responders can do in the field. When there's internal bleeding, the most we can do for the most part is treat for shock, but there's very little else that we can do. Now, external bleeding, that we can do a lot with. It's controlled by direct pressure over the bleeding site with your hand, but preferably with a cloth or bandage between your hand and the open wound. This is not to absorb the blood. The bandage is there is to provide an even pressure across the wound. On a really gushing blood, nasty wound that's bleeding, expect to apply direct pressure for 10 or more minutes. If the bleeding is not stopping after 10 minutes, remove the bandage and check for the source of blood, then reposition your hand and to stop the bleeding. We used to teach, don't remove the bandage. Now they've discovered that it makes more sense to remove the bandage and then check and reposition your hands. Either use your full hand or 2 fingers, direct pressure, depending on the size of the wound. Don't peek. Keep the pressure there for 10 to 15 minutes and then see if it's slowing down. If the wound is so profound, it is okay to use a tourniquet. A tourniquet is, you will not risk the limb if the tourniquet is only on for up to 6 hours. Beyond that, you begin to risk the full limb. So again, this webinar, I'm not going to go into the details for how to do a tourniquet. And the first aid course will teach you how to do it. But tourniquets are a way of basically closing off the bleeding. And I just got an email from a friend, also teaches for Africa Fire Mission, who said he was teaching a course in Malawi called Stop the Bleeding, and was talking about the use of tourniquet. And he said that even when people have an idea of what a tourniquet is and how to use it, they almost never make it tight enough. So he was saying, emphasize that if you have an idea what a tourniquet is and you find yourself in a need for using one, make it tight, really, really tight. So here you are in the woods, in the field, someplace far from any particular, medical care. Who knows? I don't know what you carry by way of medical supplies with you. So how are you gonna care for the wound? So let me just start by saying there's no easy rule for deciding when bleeding is severe. A rule of thumb is that if it looks like a lot of blood, then it probably is. However, it is worth noting that severe bleeding can be missed if the patient is wearing a lot of clothing or the blood is absorbed into the ground around the patient, which I've already said. I was out once with my son, and he slipped and he cut his arm on a rock, and it was an ugly looking cut. And here on his forearm, I mean, just 3 inches long and opened right up, but there wasn't a drop of blood. It was very strange. I bandaged his arm up really tight because I figured it was probably getting about ready to start bleeding. Bandaged his arm up really tight, and then we hiked out from where we were. It was about a 3-hour hike back to our car. From there, it was an hour drive to the hospital. It still had not bled, but he got 15 stitches in his arm anyway to close the wound. It was just the way he cut it. So wasn't severe bleeding, but it was a severe cut. And it's just sort of a kind of an interesting side story. So you want to clean it out. You might have to improvise how you're going to do that, but essentially what you want to do is you want to squeeze, you want to get hot, kind of some pressurized water into the wound to clean out as much dirt as possible, especially if you're going to bandage it up and it's going to take hours to get to additional help. You don't want to, as to the extent possible, you don't want to close in contaminants that can cause an infection. So if you have a syringe, you can use it to squirt the water in there. But here's a couple other things you can do. You can take a plastic bag and you can poke a small hole in it and then squeeze the water out of the plastic bag under pressure to help clean it out. That's a way to clean the wound out. Another thing you can do if you need to close the wound because of where you are and the time it's going to take, you can use things like tape. Just tape it closed up to keep from bleeding too much. There's some other things you can't really tell from this picture because I realize what this is a picture of is a person's hair and gloves, and person's hands and gloves, and they're using the hair to cover up to kind of hold the wound closed. It's not a really good picture. I probably should have taken it out. But so you want to clean it and you want to stop the blood. Now let's move to the next level, the disability state. This is another way of saying this is level of consciousness. We often abbreviate this as LOC. What you want to remember with level of consciousness is that there's 4 basic levels of concern for us. Now, each of these levels can be broken down into V, V1, V2, P, P1, 2, things like that. But for our purposes, you want to think in terms of AVPU. A stands for awake, alert, and responds to verbal communications. V is verbal, responds to verbal stimulation, but not awake. So let me clarify this because A and V can be confusing. If you're lying there on the ground and I say to you, what hurts? And you say, my leg, that means you're responding to a verbal communication. If you're lying there and I yell, are you in pain? And you go, oh, you're responding to verbal stimulus, but you're not really conscious. So A, awake, means you can actually verbally communicate. V means you can respond to verbal stimulus. P, pain. Not are they in pain, but do they respond to painful stimulation? So with at the P level, you're unconscious. You're not responding to verbal stimulus. So now I'm going to see if you respond to pain. And I might do something like pinch you or rub my knuckle against the palm of your foot. Any way I can try to see whether you're going to react to some sort of response to pain. Now, it's not going to be a verbal response. You're not going to go, yo, that hurts. You're going to go, you might, move your leg. You might, have some sort of reaction. Or you might moan because I've caused the pain, but you're responding to pain. And finally, there's you're unresponsive. So AVPU. So you should always assume a neck injury if there is a head injury. And major injuries that include things like broken bones or the mechanism of the injury suggests that there could be a neck injury. And why the neck injury is so important is because if you move the neck when they're unconscious or in one of the less than alert states, you can cause severe and life-threatening or permanent damage. So remember, disability level of consciousness, A, V, P, or U. Here's another thing to pay attention to in terms of whether or not there's been a head injury. You're going to ask yourself these questions. And while I'm reading these to you, take a look at the eyes in this picture. Notice that this pupil is larger than this one. So are the pupils equal, round? Are they reactive to light? If the answer to these questions, of any of these questions, which we call PEARL because that's the acronym, if the pupils are not equal, there's probably a head injury. If they're not round, suspect head injury. If they're not reactive to light, suspect head injury. Okay. I'm going to pick up the speed a little bit here because I've got one eye on the clock. So quick talk here about exposure and evaluate. We'll get to the next couple slides, but exposure is just a couple quick shelters that you could put up if you need to, whatever you need to do to protect somebody from the environment. Okay, we get into the evaluation stage. This is the secondary survey. In detail, a secondary survey, we're going to do a head-to-toe exam. Head to toe. We are looking, listening, feeling, and smelling, and asking for what hurts or feels odd. What is the patient's chief complaint? Do you smell anything abnormal? Do you feeling for wounds, deformities, and hardness? I'm going to say a little bit more about that later. And you're listening for abnormal sounds. And we're looking for wounds, deformities, etc. So you're using your senses. Look, listen, feel, smell, and ask. Secondary survey is going to involve your vital signs, respirations, heart rate, pulse, skin tone, etc. And finally, we're going to look at something called S.A.M.P.L.E. This is usually done in this order, as I've laid it out, but S.A.M.P.L.E. might be done first if patient is losing consciousness. Again, I will explain S.A.M.P.L.E. in the next couple of slides. Explain the purpose of this exam to your conscious patient. In the process, you don't want them to think that you're looking for their wallet or, touching them inappropriately. So you want to let them know what's happening, let them know what to expect. And also, all along the way, ask them to tell you what hurts. While you're doing this, document your findings. It helps to have someone with you as you're doing this. They can write the things down as you do your survey. And in your survey, include the time of the day the exam was conducted. Okay. And always, during this process, control the movement of the patient's head because you don't want to add any injury to the spine, to the neck or spine. You start at the head. You check the hair, check for fluid coming out of the mouth, eyes, nose, pupils, etc., continuing all the way down. And don't forget to remove a patient's hat if he or she is wearing one. And you go all the way down the legs, into the shoes, and to the toes. Okay, quick bit about heart and respiration rate. File these numbers in the back of your brain someplace. Normal heart rate, 60 to 100 beats per minute. That's normal. Some people have a lower heart rate. Some people have a faster one. but this is the general. If something is decidedly off the norm, you have a problem. When there's a problem with the heart rate, there's a problem with circulation. Normal respiration, 12 to 20 breaths per minute. If their breaths are way less, you have a problem. They're having trouble breathing. If their breaths are very, very fast, something else is wrong. Might be related to blood loss. When you're taking the pulse, you could take it at the wrist and you could take it at the carotid artery. We'll talk a little bit about pulse sites in a second. You want to take vitals every 15 to 30 minutes if the victim is stable, more frequently if the injuries or illness is severe, and always document when you take the vitals. Okay, just a little bit about pulse now. If you don't have you don't have a blood pressure cuff with you, here are some things to keep in mind. It's called the 80-70-60 rule. The radial pulse always disappears before the femoral pulse, which always disappears before the carotid. And I'll point out to you on a body where those pulses are. So when you feel for the carotid pulse, that's up here, right? So if no carotid pulse, the person's heart's not beating. The femoral pulse is down in the leg, which I can't show you sitting here, and the radial pulse is either in the wrists or in the feet, and I'll show you where those spots are. If you can't feel a pulse there, you got to go to the other places where the pulse will be stronger. Remember, if there's a problem, the extremities are going to be shut off because they're less important than the vital organs on the inside. I mean, the center of your body, your lungs, your heart, those vital life organs. You can lose your fingers. That's okay. I'm going to jump past this slide right now because I'm looking at the clock and I want to get to showing you some of the pulse signs. So here's the radial pulse on the wrist, just under the thumb. And you don't want to use your thumb when you check the pulse. You want to use the two fingers. There's the carotid. Again, using the two fingers, not your thumb. Here's where you want to take pulses. In your foot, in the artery, leg. But here's the femoral. So the key ones here for us are the femoral and one in the foot. And then on the upper part of the body, this is the key one for us right here, the carotid. This is important in case there's a problem with this lower part of the arm, but that's the carotid. Going back, that's the carotid. That's the key one. One in the foot, the one in the hand, and here's the femoral on the inside of the leg. Those are the key ones. No pulse here. That's not good, but not as bad as, and no pulse here, not as bad as if there's no pulse here. Okay, let's talk about S.A.M.P.L.E. S.A.M.P.L.E is an acronym. It's a series of questions. What symptoms does the patient exhibit and or states she has? This is what you want to put into your notes. We call these SOAP notes. Next level of first aid training, learn about the SOAP notes, but you want to put those in there. What are the symptoms that the patient is exhibiting or states she has? These are not your life-threatening ones. We're talking about in your secondary survey. You want to know, are there any allergies? If so, what? You want to know if the patient is on any medications or using recreational drugs. Recreational drugs can make a person act and seem like they're very sick. One day, a couple of years ago, a neighbor called and said, Howard and Gail, you have to come over. Something's wrong with me. I'm having some kind of medical problem. We go over. Her heart is racing. Her breathing is fast. She's all flushed in the face and she's agitated. We're like, what happened? Well, it turned out she had eaten a cookie with pot in it that she didn't expect. And so you want to know, are you on meds? Are you on recreational drugs? It's all part of being able to assess what's going on. Any pertinent medical history. Is there anything going on with this patient that you ought to know about that might help you, in terms of providing care for them? You want to know last ins and outs. In other words, when was the last time did they eat something? And when was the last time they urinated or defecated? This is important in helping you understand what might be part of their problem. Maybe they're dehydrated. Maybe they're constipated. It's part of what we call the sample. Then the last is events, and it really is like what events led up to the injury. Okay, if it's a car accident, we got it, it's clear. But you get called into a situation where a group of people are out on a walk or something. It's like, well, what happened to them? Did someone step on a bee's nest and they got stung by bees? Did they walk under a tree that fell on them? So what created the situation that brought them out there? I'm going to just show you this real quick. You can go back and look at this, but because of time, I'm not going to go into details. This is a set of things that you're looking for in the body. You're checking for any of these different situations as part of your secondary survey. And I want to wrap up by just talking a little bit about a couple of generally not life-threatening injuries that you might encounter. One is a puncture wound. Puncture wound is a hole in the skin made by a sharp or pointed object. The area may be bruised or swollen. You may have bleeding, pain, or trouble moving the affected area. Wound cleaning may be needed to remove dirt or debris. And it's important because it'll decrease the chance of infection. And remember that punctures often put, they can drive dirt in deep inside, and you don't want to close up the wound and trap the stuff inside. But the thing about punctures is that sometimes the object that punctured you doesn't get pulled out. Then it's an impaled object. So impaled objects are objects that have punctured the body's soft tissue and are still embedded. Depending on the location of the impalement and the size of the object, you may have to provide emergency care. Small impaled objects such as splinters or fish hooks can generally be removed without more advanced care. But any other impaled objects, it's not a small little impaled object, you do not remove. Do not remove the impaled object. Expose the wound area. Use direct pressure to control bleeding if there's profuse bleeding. Manually stabilize the impaled object. So they're wrapping it up. Secure the dressing in place. Take care of them for the shock and get them to help, but do not pull the impaled object out. You will cause more damage if you do so. All right, bone fractures. Again, all kinds of bone fractures. As far as you need to know as a person out in the outdoors, it's really two things. Is the bone sticking out of the skin? And then now you've got a compound fracture, you got a problem, you have to deal with the open wound. And is it or not? You can look at the slides later and learn more about these different kind of fractures, but for all intent and purposes, your treatment is going to be the same. You treat for fractures. Injuries that cause fractures can also cause severe internal bleeding. Keep that in mind, because it can sever an artery or puncture something else. Before you treat the fracture, you need to check for signs of internal bleeding or nerve damage. And the way we do that is through circulation, sensation, and movement, and checking the CSM. Here's how you check for CSM. You check the color of the limb below the fracture. Is it blue or purple? This is a sign. If it's blue or purple, it means the limb isn't getting enough blood. You need to address that. Check the pulse below the injury. Can't feel a pulse? Is the pulse weak? Compare it to the other part of the injury. If there's no pulse, you need to address that also. These are all this is all part of the CSM checking stuff. Now let's talk splinting real quick. Again, this is something you need to do with hands-on, but just to give you a quick run-up, Splint works like a temporary, we call exoskeleton. Its job is to hold the broken bone in position and immobilize it so further damage doesn't occur. That could be either to the bone or to even something inside the body. There are three components to the splint. There's the actual splinty material or rigid material. There's what you're going to use to fasten it all together, and there's padding. Don't underestimate the importance of the padding. Tissue around broken bones will swell up a lot. If there's not enough padding, the splint will cut off circulation and can cause severe damage, not to mention a lot of pain. It is actually more important for the splint to be really well padded than to be rigid. You have to be creative when you're improvising splints. When you arrive at a scene in your fire truck, you may not have first aid equipment, so you're going to use whatever you can to make your splint. Keep this principle in mind. It's called buff. Big, ugly, fat, and fluffy. That's what you want your padding to be. You're going to use adequate padding. And you're going to wrap it around the splinting the material or the limb, doesn't really matter. And you're going to use at least 2 splints, one on either side of the broken limb. And you're going to make sure the splint is long enough to include the joints above and below the injury. I'm not going to go into the details here, but I'm going to show you 2 examples of splints. Here's one for lower leg. Notice how the ankle is included and the knee. Here's an arm, elbow included and the wrist included. Another picture of how things are bound. And with that, I'm about to run out of time. So let me just say, as always, I finish every training with, we don't rise to the occasion, we fall back on our training. It's great that you guys are all of you are here getting training. This is an introduction to first aid techniques for when you're in the field. Finally, have faith in God, but trust in your training, because when you're dealing with a person who's lying there, they may be praying for help, but they're also praying that you are well trained and can help them out. So we've run up against the clock. And I see there's a bunch of notices in the chats. I hope they're not questions for me, but what I'm going to do now is I'm going to stop. I know that I've poured a lot of material out here for you. The PowerPoints will be available, and you can go through this and use this as a basic, sort of a basis for further first aid training. So at that, I'm going to just go back up to my thank you slide, leave it there, and then check the chats to see if there's, I guess Leah would have told me if there were questions. So I'm going to invite you to ask any questions you have or comments. I'm not in a big rush. So if you have any, feel free to unmute and ask me your questions.
Awesome. Thank you so much, Howard. Before we do questions, I am just going to wrap it up. That way we can stop recording and then we can go into tea time, and we'll both, since Jose, our fire safety advocate, usually does tea time, and he's wonderful at his job, but we will just take over for him today. I do see we have one question in the chat that was just asked. Cyrus, I do see you, don't worry, but we will just talk about that in just a moment when we enter tea time. I just wanted to remind everybody that this was recorded and it's going to be posted up on our YouTube channel. And so you're always more than welcome to refer back to that and watch that if you ever want a refresher. I know Howard was saying there was definitely a lot of material covered today. And so if you ever just want to look back on that, it'll be up there for you as well as the presentation. And I also invite everyone back to join us next week. We have Krista Nielsen doing some quick drills, is what her session is over. And so it'll be another great session. So I just want to invite everyone to join us for that, and invite any of your colleagues or those that are interested in the fire service to join and register as well. Everyone is more than welcome to join. And with that, I just want to leave you with saying that you will get your certificates today as long as you attended 75% of the training. So thank you so much, and we will hop right into tea time. Bye-bye.